Hi, everybody. Welcome. All right, well, I'll go ahead and get started here. So to give you all a little bit of context, we're going to be talking about understanding the difference between school and ABA therapy throughout this webinar. My name is Gina Richig, and I'm currently a behavior analyst at Bierman Autism Centers in Dublin, Ohio, and I'm at our center right now. I obtained my master's in education from Vanderbilt University Peabody College. And prior to attending Vanderbilt, I worked as a special education teacher with kids in kindergarten through 4th grade. So I have some background in the school systems. So just to let you all know, everyone is going to be muted. If you want to ask a question, I found out that you can't unmute yourself, but feel free to type in the chat or use that Q&A feature. We want the presentation to be as interactive as possible, so feel free to ask questions in the chat throughout. I have the chat pulled up so I can see. And you can also use the Q&A feature, which we will be going through at the end of the presentation. So to give you a little bit of information about Bierman Autism Centers, Bierman Autism Centers is a place where young kids engage in play to learn foundational skills they can build on, such as self-advocacy and communication. We recognize that every kid's success is unique, and our one-on-one approach allows us to drive progress using measurable outcomes while each child is advancing on their own terms. Our team is dedicated to making learning welcoming and fun by erasing the line between learning and play. Kids at our centers enjoy taking on new challenges and become motivated as they learn new skills. Our approach ensures kids become confident and empowered lifelong learners. The Bierman Circle of Care and Support includes the whole family, not just the child. We empower parents through training and collaboration. This next slide includes the pillars of our values. Our first pillar is let kids be kids. We accept every child for who they are, a unique person. Our second pillar is learning through play. We erase the line between learning and play to keep children engaged and motivated. Empowerment is key. We use everyday activities to teach children foundational skills, such as self-advocacy and communication. Engagement with families. We believe in the importance of building connections and working toward shared goals. Commitment to progress. We are dedicated to each child's everyday and long-term progress. A couple of objectives for the webinar today. The first one is to review what IDEA and LRE are, and you'll understand those acronyms as we progress. To compare and contrast different learning environments. To discuss similarities and differences between ABA therapy in centers and school-based education. To describe how ABA therapy supports learners in transitioning to less restrictive environments. To summarize the purpose and use of an IEP. And to summarize the purpose and use of an ABA treatment plan. So to jump on into IDEA and LRE, the Individuals with Disabilities Education Act, or IDEA as it's better known, is one of the most influential laws supporting the education of students with disabilities. IDEA is a federal law that guarantees all learners with disabilities a free and appropriate public education in the least restrictive environment for that learner. So that's where we see that LRE come in. The least restrictive environment, or LRE, for a child depends entirely on their strengths and needs as an individual and can be different for every learner. The goal of the least restrictive environment is to provide the learner as much time as possible, learning alongside peers without disabilities. Some provisions of LRE ensures that, to the maximum extent appropriate, children with disabilities, including children in public or private institutions, or other care facilities are educated with children who are non-disabled, and special classes, separate schooling, or other removal of children with disabilities from the regular educational environment occurs only if the nature or severity of the disability is such that education in regular classes with the use of supplementary aids and services cannot be achieved satisfactorily. And this second bullet is very important. Sometimes we need a separate environment so our learners can reach their full potential, and then we can move them to a less restrictive yet still effective environment. LRE is important. The least restrictive environment provides opportunities for all children with and without a diagnosis, which is very valuable for everyone involved. LRE is a foundational element in building an appropriate individualized education plan, or IEP, that can improve outcomes for a child in school and in life. This here is a visual created by the Michigan Department of Education, but it applies to most, if not all, states in the US. On the left here, we have an arrow that shows the continuum of least restrictive to most restrictive environment. Then over here on the right side, we also see how that correlates with the number of learners in each of the different environments. So the more restrictive a setting is, the fewer learners are placed in that environment. Conversely, the less restrictive an environment is, the more students there are in that setting. I see a question in the chat, and I will kind of answer that in just a minute. A couple of slides from now. When considering the most appropriate, least restrictive environment for a learner, we always move from bottom to top. At the bottom, we see there's the general education classroom without supports. This setting is for learners who spend their entire day alongside peers without disabilities, learning from a general education teacher. Then this next step up is a regular classroom with consultation. So in this setting, the general education teacher is getting some advisement from a special educator about how to individualize certain aspects of their instruction for learners with disabilities. After that, we have up here a regular classroom with supplementary instruction and services. These are also considered push-in services, where learners spend their day in the general education setting, but receive some specialized services from a special education teacher who comes into the classroom to provide that additional support. Next, we have a resource program, and this is actually the setting that I taught in when I was a special education teacher prior to working here at Bierman. A resource room is a small group environment where pull-out services are provided. Individuals with disabilities come to a resource or special education classroom for varying amounts of times to work on specific skills based on their strengths and needs. Then up here, we have a separate classroom setting. This is also sometimes referred to as a self-contained classroom. Learners in this setting spend most or all of their day in a separate classroom, receiving education from a special educator. Here in the golden yellow color, we have a separate school setting. This setting would be a school that's specifically for learners with disabilities, which means there are not any opportunities to learn alongside peers without disabilities. In the light blue, we have a residential school setting. The difference between a residential school and a separate school is the time the learner spends there. In a separate school, the school hours are usually the same as non-specialized schools. So 7 to 3, 8 to 4, things like that. A residential school setting has learners that live there full time, So they spend 24 hours a day in that facility. And then here at the very top of our continuum is the homebound or hospital setting. This setting typically has little to no daily peer involvement with any peers, so peers with disabilities or peers without disabilities. Now, you might be thinking, so what determines the most appropriate learning environment for my child specifically? And to answer your question, the truth is there are a lot of different factors to consider. Least restrictive environment recommendations are typically made based on the results of a variety of assessments that include things like standardized assessments, which look at the differences between scores obtained by the learner and scores that would be expected from a typically developing child. Assessments may also include observational assessments, so looking at how the child interacts in certain settings, how they socialize with those around them, and how they perform routine tasks of daily life, such as self-feeding or toileting. Once a learner is placed into one of the settings on the continuum, it can be difficult to progress down to less restrictive environments. And this is really where ABA therapy comes into the picture. And then to answer the question that was in the chat, they asked who determines what the LRE is and whether or not the learning is being achieved. And that really depends on the setting that you're in. So in school settings, the least restrictive environment is typically determined by the IEP team. So when the meeting happens with a special education teacher, sometimes there might be a special education coordinator, sometimes the general education teacher's involved, and then the parents or caregivers are also involved in that. That whole team convenes together to determine what setting is most appropriate for school systems. For therapy, ABA therapy, if we're talking about center-based ABA therapy, sometimes the insurance companies will determine how much hours a child is able to receive through the insurance. And they base that on the assessments. And sometimes if a clinical recommendation is not approved, there may be some back and forth and making some appeals and things like that to try and communicate to the insurance companies why more hours might be recommended than what they had initially approved. So I hope that answers your question. And if you have any follow-up, please feel free to send it in the chat. So what exactly is ABA therapy? ABA stands for Applied Behavior Analysis, and therapy is based on the science of behavior. We use this science to assess and treat socially significant behaviors, which essentially means that we support our learners with developing skills that are valuable to improving the quality of their lives and skills that are valued by the learner and their families. ABA therapy can be provided in a variety of settings, which includes clinics or centers like here at Bierman, and there are also home services, and some schools have BCBAs who work for them as well. An important goal of ABA therapy is to facilitate a transition to a less restrictive environment. But how do we do that? By teaching kids the skills they need to be successful in those less restrictive learning environments, and helping to reduce the gap between the abilities of learners with disabilities and typically developing learners. Looking at center-based ABA services in particular, such as Bierman, services are provided through these settings and are funded by insurance companies. They also meet the medically necessary criteria. This means that the focus is on addressing the core symptoms with autism that may interfere with the learner being able to learn new skills from other settings, such as the school setting. Center-based ABA services target communication skills, social skills, and independence skills. We work on decreasing barriers to learning such as challenging behavior, prompt dependency, and restricted preferences, and more. Since center-based ABA services are a medical treatment, the focus is on teaching skills that are necessary for someone to function in the natural environment. I see another question in the chat about deciding between ABA and developmental preschool if there's not an option to do both. In that situation, I would definitely talk to the providers in both of the settings and see what their recommendations are, and taking into consideration the learner's needs. So if the learner needs to develop some skills before they're able to go to preschool and be successful in that environment, ABA therapy might be a good fit because it'll help to prepare them for that setting. But if they have all the prerequisites they would need to go to that setting and be successful there, then you might be able to do preschool. I would recommend trying to talk to the providers, get some information about where your learner stands in comparison to those typically developing peers, and also information about what kinds of supports would be available to the learner in each of those settings to see what might be the most appropriate fit. So I hope that's helpful. Yeah, of course. A few of the core areas that center-based ABA services look at supporting are social, occupational, and other areas of functioning. These often relate to the safety of the learner or their ability to function in the school, home, or community settings. The social area of functioning relates to or involves activities in which people spend time talking to each other or doing enjoyable things with each other. So spending time with friends and engaging in meaningful activities with others. Think about the learner's ability to make friends or develop those meaningful social relationships. Occupational refers to the ability to perceive, desire, recall, plan, and carry out roles, routines, tasks, and subtasks for the purpose of self-maintenance, productivity, leisure, and rest. So this incorporates coping skills, independent play skills, and skills that would be necessary to have before being able to work a job one day. Some other areas of functioning may look at safety concerns, such as behaviors that may be dangerous to the learner or others. This could also include how much support the learner would need completing daily living activities, such as independently following school routines. I see another question in the chat. So the question says, I've heard that multiple settings are less appropriate for children with autism because they need to acclimate to multiple settings, rules, etc. Is this true? Or is a combination a better option since school focuses on academics, etc., while ABA focuses more on learning basic skills and functions? So to answer that question, I would say it's really going to depend on the learner and their needs. A lot of these things have to be individualized to each child. I wouldn't say that settings are less appropriate for children with autism as a general statement. Autism is a spectrum, so we have kids all over the spectrum. And research also shows that ABA is effective for kids anywhere on the spectrum. So it can be helpful for kids with all sorts of skill sets. When thinking about whether a combination would be better or trying to focus just on school or just on ABA, again, I would say it really depends on the learner. For example, if there was a learner who wasn't able to sit at a desk for more than 2 minutes, wasn't able to attend to materials that are presented to them, going to a school setting probably wouldn't be that beneficial because they don't have those skills that they need to be able to sit and attend to learn that academic content. And those are types of skills that ABA can help teach through the use of reinforcement or by rewarding when kids do engage in those behaviors, like sitting or attending to materials. So being able to practice that more will help prepare them to transition to that less restrictive setting of maybe a general education environment or special education supports in school and things like that. So I hope that answers your question, and please feel free to send any follow-ups if you have any other information that you wanted to ask about. So here on this next slide, we have some comparisons between school and ABA. Looking at some of the similarities and differences between school-based education and center-based ABA therapy, the school setting typically has a strong focus on teaching academic skills, such as reading, writing, math, social studies, history, and science. There is typically some incorporation of related arts, which can include things like music, art, health, and gym. And there may be some focus on social skill development and social emotional learning. But this is still an emerging component of school settings and is not as thoroughly developed as social skills taught using applied behavior analysis. So applied behavior analysis may be more beneficial for kids with more impactful social struggles. The school setting also typically includes opportunities for peer interactions with peers who don't have disabilities. Now, if we look over here on the opposite bubble, center-based ABA therapy has a strong focus on teaching skills that are prerequisites to learning in school settings, such as sitting in a chair, staying, excuse me, staying at a table, attending to materials, tolerating following adult directions, tolerating working for extended durations, and so on and so forth. Center-based ABA therapy also teaches social skills more explicitly and systematically. We teach appropriate communication skills for wants and needs, and we teach waiting and tolerating denials when our learners can't have the things they want exactly when they want them. So these are all skills that are important to have and oftentimes necessary in a lot of school settings, and they're not taught explicitly through the school system. That's why ABA therapy works so well to help prepare kids to transition to school settings. Now here in the center of our Venn diagram, we have some areas where school-based education and center-based ABA therapy tend to have a little more overlap. Both settings facilitate greater independence for the learner, just in different aspects. Both settings also use research-based interventions for teaching. And both settings may teach daily living skills such as self-feeding, hand washing, and toileting, depending on the learner and their individual needs. To expand a little bit more, clinical ABA therapy or center-based ABA therapy is intended to treat the symptoms of autism. The focus is on accelerated learning to close the gap with same-aged peers. One-on-one services with group opportunities are provided with that one-on-one assistance during those group activities. So they still get that extra support even when they're practicing skills as a group. Progress is reviewed weekly to adjust teaching strategies and targets quickly. Small caseload sizes allow the BCBA to provide some close oversight of their cases and closer training to staff. ABA programs are funded through private insurance and Medicaid because ABA is considered a medical necessity. School-based programs, on the other hand, are intended to provide a free and appropriate public education. The focus is on the ability of the learner to access the curriculum with modifications as needed. School-based programs typically provide learning in the classroom or in small group settings. Progress on IEP goals are reviewed quarterly. There are no regulations for caseload sizes for BCBAs who are working through the school system. So BCBAs may be shared across classrooms, across schools, and across districts. Public education is supported through federal, state, and local funds. So why is ABA important? It fuses science and learning. We use scientifically proven teaching techniques to teach children who have difficulty learning, especially in other settings. Research has shown that early and intensive ABA therapy promotes better treatment outcomes. Intervening early makes it more likely to close the gap or catch a child up to the level of typically developing peers. ABA therapy is effective for any child, regardless of their age or where they fall in the autism spectrum. Research has also shown that 40 hours of therapy promote better outcomes when compared to less time. Even when compared to 30 hours, 40 hours per week always produces the best outcomes when comparing the intensity of treatment in the literature. Research also shows that anything less than 30 hours per week for a child in need of a comprehensive program is often not effective. And keep in mind that is for clients who have more intensive needs, so they really need that additional support. The goal of ABA therapy is graduation to a less restrictive environment. The bigger picture includes the vision we have for the learner. The goals of education for individuals with autism spectrum disorder are the same as the goals for any other student. That is, to provide opportunities to acquire skills that increase personal independence and social responsibility. Graduation from ABA services means that the learner has met most or all of their behavior change goals. They have gained an increased level of independence and an enhanced skill set. There is a decreased need for long-term care and decreased need of intensive supports, so they need less intensity of services. Graduations move learners to a less restrictive level of care. And this is our end goal for everyone. So how does a successful graduation happen? Through teaching and building skills up to independence. We focus on teaching skills across several areas, including communication, social and play skills, resilience skills, and independence across different areas. Our teaching incorporates all relevant environments and teaching targets. So this includes teaching learners to be more prepared for school, home, and community settings. We address each area of difficulty for our learners until they are able to reach that independence. Many of our learners have behaviors that interfere with their ability to learn in less restrictive settings, such as elopement, aggression, self-injury, or tantrums. In these situations, teaching adaptive skills as replacements for these behaviors is essential. We want to teach communication skills, resilience skills, and self-advocacy so that we can fade supports and help our learners be more successful in the natural environment. The progression of therapy over time incorporates the decrease of interfering behaviors and the increase of functional communication, self-advocacy, resilience skills, and problem-solving skills. For example, a learner who hits others when asked to put away toys might be taught to ask for extra time with toys, or ask how long she might have to wait before playing with the toys again. She might be taught to ask what she needs to do to earn more toy time. And she might be taught to tolerate sharing, waiting, or doing some work before being able to play with those toys again. Another example could be a learner who likes to put toys or different inedible objects in their mouth. We can provide him with a chewy that's meant to be chewed on and kept in his mouth. We can teach him to search for the chewy when he places it down somewhere, and we can teach him to ask for a new chewy if the current one gets lost or broken. To promote more comprehensive care, center-based ABA services typically value teamwork. Service providers will attempt collaboration with all relevant people, which is an important aspect of programming. Family involvement is focused to ensure that the family vision aligns with clinical recommendations and the skills being worked on with the learner. We will also incorporate peers to work on developing social skills needed for settings with a variety of peers. We will collaborate with other professionals involved in treatment, including behavior technicians, occupational therapists, speech therapists, and other relevant service providers. So the next thing we'll do is talk a bit about different types of individualized plans. So to guide programming for learners, there are a variety of different types of individualized plans. The treatment plan is what we use here at Bierman to guide our ABA services. The treatment plan is a report submitted to insurance companies. It explains the needs of an individual and why services are needed. It follows the medical model and must meet medical necessity criteria. It's typically completed every 6 months, but the length may vary based on the insurance company. The next type of plan is an IFSP, or an Individualized Family Service Plan. This plan targets children from birth through the day before their 3rd birthday. There's a focus on providing early intervention services. This is based on an eligibility assessment, and it includes annual assessment and goals, which are reviewed every 6 months. The next type of plan is an IEP, or Individualized Educational Plan. And this is one of the most common plans that we'll see for students with disabilities in the school setting. It is a written plan including free special education, related services, and supports to meet the child's unique needs. It includes specialized instructions. It starts at age 3, and it requires a diagnosis that affects educational performance. So that part is very important. The IEP also includes annual goals. And our last type of plan here is a 504 plan. This is a plan for how the school will provide free supports and remove barriers so a student can learn alongside peers. A disability that limits one or more basic life activities would qualify for a 504 plan. It includes specific accommodations and supports, and the length that a 504 plan stays active for varies based on the state. To expand a bit more on the ABA treatment plan, it typically includes 15 to 35 goals, depending on whether the child receives part or full-time services. These goals are expected to be mastered within a 6-month timeframe. The purpose is to identify skills to be taught that will mitigate the symptoms of autism that make it difficult for learners to thrive in school settings. These skills are taught through repeated practice and highly motivating rewards for correct responses. So when we see kids doing the things we want them to do more often, we'll give them something that they really enjoy to try and see that behavior more frequently. An individualized education plan, or IEP, is reviewed annually. It typically possesses around 10 goals that are to be achieved within the time span of a year. So that's a different comparison if you're looking at an ABA treatment plan as opposed to an IEP. The way that they track their data and how they update the goals and things like that are pretty different. But the purpose of an IEP is to develop modifications and/or accommodations for the learner to be able to access core curricula and progress towards meeting academic standards. So the purpose of it is different. That's why we see different goals and the different time span there. Short-term goals of ABA therapy are developed every 6 months in the treatment plans that target smaller components of larger skills and address skill deficits. These small steps are needed at the beginning and throughout therapy to build up to those long-term goals. Long-term goals focus on the bigger picture, such as the learner meeting all of their behavior change goals to become ready for that less restrictive environment. When looking at how our short-term goals can be built upon to reach long-term goals, think of communication. When we teach communication, we may start with teaching just a few words for the child to request highly preferred items, but the larger long-term goal is for the child to use language to request a wide array of things, to make comments, to tell you about their day, to answer questions, to have conversations with others, and things like that. At the beginning stages of ABA therapy, intensity is key to address as many short-term goals as possible until learners can catch up to the levels of their same age peers. While ABA is generally a long-term commitment that a learner and his or her caregiver makes, oftentimes before the child reaches his or her third birthday, it is still important to have a fade-out plan in place for when the learner reaches their treatment goals or the provider is no longer able to provide services. We want our learners to reach a point where they no longer need our services. So here are some tips to ensuring that your child has a fade-out plan that is supportive of transition out of services. One point that's important to consider is that it has a clearly outlined eligibility, timeline, and fade-out procedure. The fade-out plan should explicitly state the conditions that qualify a learner for fade out of services, and oftentimes this information is included in the treatment plan. So for example, if the learner is no longer benefiting from services, if they no longer require the services, if a caregiver requests discontinuation, and so on. In addition, a fade-out should provide the family with a transition plan detailing when caregivers will be notified of discharge date, and resources that should be provided for addressing any remaining areas of need for the learner. Having a clear plan takes the guesswork out of the process of transitioning out of services. The plan supports client independence and focuses on teaching functional skills. The long-term goal of ABA therapy is to help individuals learn functional skills that can help them integrate into an inclusive environment. Treatment plans should address functional skills first, in order to ensure that each learner can achieve maximum independence if services are no longer available. Transition should also include planning ahead for at least 6 months prior to the last date of service. At Bierman, we structure our treatment plans to account for and support transition out of services to ensure that fade out does not feel sudden or disruptive. Treatment should always maximize opportunities to use natural teaching strategies and caregiver training and support. Developing a network of professionals and community partners to assist in the transition of care is key. This involves collaboration with other providers to provide resources for learners after they transition out of formal ABA services to maximize skill maintenance and continuity of care. And our last one is including an aftercare plan with follow-up consultations when possible. Providers should schedule follow-up consultations with caregivers after transition out of services to help troubleshoot issues that may have arisen post-transition. So don't hesitate to reach out to providers if they don't reach out to you first. It's important that the transition of care goes smoothly for the learner. To wrap up, intensive services are crucial at initial stages for some learners. Center-based ABA services help develop abilities necessary for learners to function in a less restrictive environment. Providers should work with the family to determine short-term goals and establish long-term goals based on that vision. Collaboration with school personnel should happen for a successful transition from center-based services to school-based education. And our goal is always graduation to a less restricted level of care. This is where I got that graphic for the least restrictive environments for that little flow chart that we saw earlier. That was the website I pulled it from. So thank you guys so much for attending, and I hope you all have a great evening.